know this video raises many questions actually and many debates, but I'd rather delay the discussion till the end because we are running late more than 30 minutes. So we are proceeding to our next speaker, who will be Professor Dr. Sameh Al-Noumani of Cairo University. He will be talking to simultaneous abdominoplasty and cesarean section, pros and cons. Please, Professor.
Thank you for inviting me to this valuable conference, and thank you for the park for allowing me to park there. I promise you I'll not exceed the limit of the lecture. My lecture is abdominal wall rejuvenation and C-section, a combo procedure with cons and pros. We have come a long way since the days when abdominal wall contouring was performed by simple dermal lipectomies, with no attention to diastasis correction and muscular reinforcement, pubic rejuvenation, and little regard for the final aesthetic result. The plastic surgeon has become capable of remodeling the entire trunk, assuring removal of considerable amounts of adipose tissue. We can transform the abdominal shape to a more beautiful one by remodeling our technique, not simply by excising skin and only by doing simultaneous liposuction and liposculpture. Flat abdomen is a desire of every female, though pregnancy disturbs such appearance. It is distorted when abdominal muscles and fascia are stretched along with skin. There may be fat deposition of different grades. However, it's not a miracle. Mom should be realistic. It's not just factory. There are two reports in literature which depict the cesarean section shouldn't be combined with an tummy tuck or abdominoplasty procedure, as it's fraught with danger. The first lecturer was Ali and Assam in aesthetic plastic surgery, 2011, and another is Thabit et al., International Journal of Women Health, 2012. In our current study, the concept has been changed to prove that the combo procedure can be safe by successfully combining cesarean section and abdominoplasty in 25 patients with adding some technical modifications. So, why we are trying to change the concept? We have first the concept of expanding the abdomen by the baby, the water inside the uterus or inside the tissues, the blood inside the uterus and inside the tissues as well. However, we have two opposing forces. We have expansion by the expanding uterus and baby inside, and we have also the recoil after then. So we have to depend on the recoil force to correct our technique. Current study aims at clarifying the technique with special concern to pros and cons of the procedure and technical modifications to maximize the aesthetic results if done at the time of the delivery. Okay, doctor, can I have my body shape back after labor? Madam, you have a storm inside your body. Calm down. Your only mission now is to be a mom. So, what are the indications of such combo procedure? When can I go for this procedure? The first indication is post-delivery appearance shock. After delivery, the abdomen becomes unsightly in almost all females. Imposed upon this curved cesarean aids the ugliness of the abdomen. Another indication is the associated ventral hernia. There is apparently no reason to refuse to repair these hernias. There are even positive indications in view of serious complications associated with pregnancy in the presence of an anterior wall hernia. In the past, we were advising the patient to delay any repair of hernia after her last labor. But now, we have a paper published in Hernia Journal called Pregnancy and Ventral Hernia Repair. They recommend doing hernia repair without doing mesh hernioplasty by a special technique so that the patient can avoid the danger of have a hernia, and she can complete another pregnancy later on. Another indication for doing simultaneous procedure is financially. It is quite convincing for women to do simultaneous technique in one session. I think it is fake for many reasons. More time, more consumables, post-operative recovery, need for another revision, and the most important, the plastic surgeon. He's the most money collector in this. How can I select my patients in this study? I have inclusion criteria. When the BMI is below 30, patient should wait until her last delivery. It must be an elective procedure. The plastic surgeon must be there. Please, no obstetrician can try to do this technique. Who are the patients who I can exclude from this study? BMI more than 30, I mean before the pre-pregnancy state. If I have complicated pregnancy, if I have a patient who is active smoker, uncontrolled diabetes mellitus, anemia, nephropathy, steroid user, gross crease fungal infection. However, the two important exclusion criteria is smoking and obesity. They can add to the morbidity for my technique, and they can add for complications. Overview of the techniques, I have two famous techniques, full tummy tuck or mini tummy tuck. The main difference for full tummy tuck, I can elevate the skin flap up to the costal margin. I can do muscle repair all over the abdomen from the xiphisternum down to the pubic area. I have longer scar from both hips. I can translocate the umbilicus from its original position. However, the mini tummy tuck, which many surgeons prefer to do in this technique, but it's not enough. I can do flap elevation until the umbilicus. I do muscle repair only in the infraumbilical portion. I can remove a small ellipse and close in a smaller wound. So what are the step sequences recommended to do such combo procedure? To my mind, the obstetrician must start the technique, cesarean section, with his classic incision. But first, I must cover the abdomen. I must seal the abdomen with opsite sheet. Then the obstetrician can do his surgery. Then I can remove the opsite sheet, so I have fully clean abdomen, avoiding of infection. I can do my liposculpture. Then I can do my tummy tuck with new lower incision. Is there a difference between scars in the CS and tummy tuck scar? Yes, my main aim in tummy tuck, not only to rejuvenate the anterior abdominal wall, also to do pubic rejuvenation. So I make a lower scar so that when I close under tension, I lower the pubic area as well as I do the anterior abdominal wall rejuvenation. I have many classic cesarean section scars like midline vertical, Millard, Joyle-Cohen, Finnish teal, and they are all away from the pubic bone. However, my tummy tuck scar is almost reaching the pubic bone. When I have to do preoperative marking, as I know, the scar is about 8 centimeters above the vulval commissure. Then I do an area of limited liposuction above the umbilicus and in both flanks to start with limited liposuction first to improve my aesthetic outcome. Liposuction can assist reducing bulges with minimal dissection, which I can avoid to avoid flap necrosis and flap infection as well. Infraumbilical dissection, supraumbilical central limited dissection. I don't have to reach the costal margin bilateral as they are doing in the bust. Now I minimize my dissection to the central area. I added liposuction first, so it can add the value of extensive dissection without doing dissection. That's called tunneling. Then I have to mark and repair the diastasis inside the anterior abdominal wall. Then I do redrabbing of the flaps. Then I do umbilical translocation. I have to position the patient before resection to 45 degrees and in some literature to 60 degrees, so as I remove the most of tissues, so as to avoid the recurrent panniculus after the patient uterus come down or relaxed or revolute. The resection of the skin flaps, is by using special maneuver or special technique or special instruments called Betang instruments, so can I determine what adequate tissues I can remove. Here are the excised portions. Here is the final appearance. We can note in this photo a good capillary circulation down to the infraumbilical portion. So what's the fate of belly button scar progression? We have belly button scar progression photos, and we notice at the end of 2 or 3 months, I have a fully normal umbilicus with a scar inside the umbilicus. What are the complications of such compo procedure? I have aesthetic and non-aesthetic complications. The non-aesthetic may be bleeding, bruising, hematoma, exsanguination, dehiscence, edema may be persistent, infection, sepsis, necrosis, necrotizing fasciitis, perforation of intra-abdominal vesicles, sensory loss, seroma, thromboembolism, toxic shock syndrome. Umbilicus may be off-center or total loss. The aesthetic complications, which are most important, may be asymmetry, dog ears, need for further surgery, which is most important, recurrent panniculus, recurrent protrusion of abdominal wall, scarring may be widened, thickened, hypertrophic or keloid, skin overhanging scar. So I have other authors, and they have outcome. The most important 2 papers and the most important extremes, I have the first paper, which published in aesthetic plastic surgery by Ali and Assam. They were doctors from Ain Shams University, and they almost insulted the technique. They produced a lot of complications, and they recommend not to do the technique. They have wound infection, wound dehiscence, lower abdominal skin necrosis, residual abdominal skin redundancy, outward bulging of the abdomen and lack of waist definition, outward bulging of the umbilicus, and anesthetic results in different proportions. But I have another extreme, another paper, which is ultra-rapid limited dissection abdominoplasty. It is safe with cesarean section. It is done in India. And as it is done in India, so all the patients are happy and the doctors are happy and no complications. It was an Indian paper, and I doubt if they have such results. But they are doing only scar revision, scar excision, and primary closure. So it's not an abdominoplasty, it is scar revision. In current study, we go more for evaluation in 2 methods, objective evaluation and subjective evaluation. Objective evaluation, we try to cooperate with a committee of 3 plastic surgeons, and subjective evaluation by patient satisfaction scoring. In the objective evaluation, we have no wound infection, no flap necrosis, and 8% remaining panniculus, which needs revision later on. However, in subjective evaluation, we have 20% of patients were not satisfied in different grades. In this study, how did we improve the results? We have first the complication of infection. We have many risk factors for cesarean section wound infection. I will not repeat in front of you because you know it more than me, but I have obesity, diabetes, chorioamnionitis, patient taking steroids or stapling, bad viewer visits, etc. But for me, I added for risk for infection, longer procedure, longer wounds, relatively hypoperfused tissues. Wounds are classically to be closed under tension. I have to close under tension. It's not a disadvantage, it is an advantage because I'm doing abdominoplasty. So what did I do for preventing infection? I used perioperative antibiotic prophylaxis. As I told you, I have opposite closure of the abdominal wall before cesarean section. So as I separate the field of cesarean section away from my field. The third is the PICO system. PICO system is a sort of negative suction, continued negative suction, and it's portable underneath the patient clothes. It is connected to negative suction with a small canister, so it can suck any exudate, any transudate from the wound. It's applied for the first 7 days, so no wound infection underneath. The second important complication is thromboembolism. In cesarean section versus normal vaginal delivery, I have 30% up to 70% in cesarean section predisposition to thromboembolism. However, I add for my tummy tuck procedure, it is a longer procedure, more losses, higher compartmental pressure, prolonged recumbency, post-operative. So I use prophylactic anticoagulation, elastic stocking, intermittent pneumatic compression. Conclusion. The bottom line from the plastic surgeon is for the mom to wait until her body has recovered from the strain of pregnancy. The best results come when a mom feels that she has reached as close to her pre-pregnancy shape or weight and is ready to take care of herself with whatever mom job she chooses for her to look and feel fantastic. We need it. It is a procedure that deserves to follow some precautions and modifications to satisfy mom needs, provided she is realistic, not a dreamist one. I have 2 cases, pre and post. Thank you.
Thank you very much for this excellent presentation. Do we have any questions, or should we proceed for the issue of time? Yes, please. One question only, please, because of time.
Yes, it's a potentially contaminated wound. I don't know the contents of what's inside, but I consider for myself, yes, I agree with you, but for me, for extra safety, yes. Okay,
We'll stop going to it. Okay.
Okay, thank you very much. May I introduce the next speaker, Professor Samer Nomani?
Yes, I finished
Sorry,
already,
excuse me,
thank you.
Professor Ahmad Zakaria, Cairo University, speaking about urodynamics and translabial ultrasound.
I'm sorry, but me, please. Dr. Ahmed Zakaria will be talking about.
Excuse me, please. Management of atypical Müllerian anomalies of genital tract.
Okay, Bismillah ar-Rahman ar-Rahim. My objective really was to address a few points. I face quite a lot of referrals with difficult Müllerian anomalies that are actually sometimes misunderstood or misdiagnosed. And I just want to address a simple way of actually diagnosing the Müllerian anomalies without the use of high-end technology by basic machines. And then I'll show you what the high-end technology can do, and maybe end by explaining a little bit about the value of the 3D imaging or rendering of the genital tract, and how we can assess actually the lower genital tract in cases of Müllerian anomalies, because this can sometimes be missed. Doctors actually focus on the uterus and cervix, and they ignore what's happening in the vagina and the external genitalia, and as well end up by when and how to treat those cases. And let's look at our old classification of Müllerian anomalies when we looked at a uterus with an indented fundus, and we call it an arcuate, or a septum, and the unicornate ones, and the bicornate. That was our previous sort of classification that maybe still applies, but the ESHRI actually changed that classification into a different one with a bit of more coding. The normal uterus is 0U, and then we have a T-shaped cavity or an infantile cavity where we call it class U1, and the septate uterus would be class U2, and the bicornate is class U3. And looking at the hemiuterus or unicornate uterus as class U4, and the complete aplastic or infantile uterus as class U5. Still, actually, what's happening with that ESHRI classification is that it still did not address what's happening in the lower genital tract, which what I'm going to talk about a little bit later. So let's go through our standard views of a uterus, and in a longitudinal section, you actually need to demonstrate the whole cervical canal and end up with a nice clear endometrium. And you need to see that the transverse section of the uterus still shows the endometrium reaching up to the fundus without any breakdown in that content of the endometrium. And As well, we need to address when we're going to examine the patients for assessment. In the early proliferative phase, you know that the endometrium can be quite thin, so the pictures will not be very clear. The late proliferative stage, you have more water or more fluidy content of the endometrium, so it's actually quite obvious and more thickened. And the late luteal phase of the endometrium is actually quite echogenic endometrium and difficult to diagnose. So our optimum time of looking at the patients would be probably around the mid-proliferative phase of the cycle. So would 3D actually change that? Yes, it does change that. It does actually give you a good image of how the shape of the fundus of the uterus works, how the cervix is like, and whether you can see any sort of focal lesions. Are those focal lesions intracavitary or outside the cavity? And as well, is there any indentation in the fundus of the uterus in cases of arcuate uterus? Because you can easily miss an arcuate uterus if you just go through the standard 2D scan. But if we still go back by the basics, then yes, if you look at the good longitudinal section and a good transverse section, you probably would diagnose most of them. And I'll show you a few tricks of how difficult ones would be. And the first one is a rudimentary horn. And in a rudimentary horn, you would not see a growing endometrium in that line because it's an uncanalized cavity in comparison to the other side where you can see a normally full-grown canalized endometrium. And the most difficult diagnosis that I find is diagnosing a unicornate uterus, because in unicornate uterus, if you do a standard 2D scan, then you'd see an endometrium that is responding, that seems to be working well. However, if you do a 3D assessment, you would see that you only have one half of the uterus developing instead of the normal triangular appearance of the uterine cavity. But the main point that will actually help you to diagnose that it's a unicornate uterus is where the ovary is located in relation to that uterus that you find. Because if you have a unicornate uterus, then the other half of the uterus did not develop, so the uterus on the side that is aplastic will be far away from where the fundus of the uterus is in comparison to the area of the normal developed uterine horn. The second point as well is looking at the uterus in a transverse section, because with bicornuate uterus in a transverse section, you will find that the two funduses of the two ends of the horns are totally separated from each other. If you compare that to the appearance on 3D, then 3D can still help you. But as well, the trick is the fundus of the uterus separated, or is it a complete uniform fundus? If the fundus of the uterus is separated with the two horns and there is a big indentation between both of them, then it's a bicornuate uterus. And if you compare it to the septate, no. In the septate uterus, you will find that the fundus of the uterus is still as one shape or one cavity, but the two endometriums have been separated together by a piece of tissue in the middle. This is a septum. And actually, if you follow that uterus downwards by that transverse section, you'd be able to tell how long is the septum. Is it involving just the upper third of the cavity, the middle third, or even reaching up to the cervical canal and dividing the whole cervical canal? And that's part of the difficulties with complete septate uterus. If you have a septum that's actually dividing the whole uterine cavity and as well as the cervical canal, you can easily think of it as being a bicornuate. But the main issue is, if you look at the fundus of the uterus and you find that the fundus of the uterus is still one shape, one cavity, and it's divided in the middle, in comparison to the bicornuate uterus, where you find the two funduses totally separated from each other and not connected together. And obviously, 3D would help you to see it and to actually delineate how long is the septum. Is it involving just the upper 1/3? Is it involving up to the middle third? Or is it a complete septum like this one here, where you find that the septum is continuing and continuing and continuing, and if you look at the cervix, you'll still find that there is a dividing line between the two ends of the cervix. But still, although 3D has helped you to diagnose that, you can actually still pick it up by 2D scan, because you would find that the endometrium in the middle of the image that you found in your transverse section is still divided by a piece of tissue, splitting it into two halves. The issue is, when you always see a septum, you have to actually assess the whole genital tract and make sure how long is the septum, because sometimes if you see a septate uterus, it's not just a septate uterus, as you can see inside the cavity, but it's actually a septate uterus, and it can be a complete septum involving the whole cervical canal, and usually those are the ones who have a longitudinal vaginal septum as well. And obviously the procedure is different, because if you're going to be doing a complete septum of the genital tract, then you will start first by doing the longitudinal vaginal septum, and then do the cervical part of the septum, And if the procedure is not too long and you have not infused the patient too much by hysteroscopic surgery, then you might do it all in one stage or divide it into 2 stages. And we had quite a lot of experience actually in my department where we used to do lots of such cases. Some of them we were lucky and we did them as in one stage, starting from the vaginal septum upwards until the whole uterine cavity septum, going through the cervical septum as well. Or we had to do it on 2 stages, doing the cervical part, the vaginal part, and a small part of the uterine one. And we stop and delay it and do it on the 2nd stage if we think that we have taken a longer period of time because of the fluid overload during hysteroscopic surgery. And here again, this is the septum. You can see the fundus of the uterus is all one, and there is a dividing tissue between that end where the sac, gestational sac, is on one side, and the other end which is empty. And as well, the 3D rendering of it, you can see the septum clearly here dividing maybe more than 2/3 of the uterine cavity. What about arcuate uterus, and is arcuate uterus important? Well, in arcuate uterus, you would find an indentation of the fundus of the uterus. Sometimes you might not pick it up easily by 2D scan, but it's not really that important because usually arcuate uterus do not need intervention, except in a small proportion of cases where we can go by hysteroscopic resection of a small part of the arcuate, maybe hoping to actually open up the cavity a little bit more to give us more of ample space. And then I end up by a couple of really challenging cases, and I've seen actually about a series of about 4 cases over the last 3 months of Hurlin-Werner Wunderlich syndrome, which is actually quite a strange syndrome where you have unilateral renal agenesis, you have a complete bicornuate uterus, and complete division of the vagina, and actually one of the vaginal ends is blocked, and it actually causes hematocolpus and hematometra on one side, and the other side is normal. So usually they either present in early puberty with abdominal pain, and we find that they have hematocolpus and hematometra on one end, and as well they have the other horn of the uterus and the vagina normal on the other end. Or I actually, the case that I'm going to present the surgical intervention of, she had a fistula between the blocked vagina and the other side, so she kept complaining of continuous brown spotting throughout the whole month because of the blood that was actually accumulating inside the occluded vagina. And actually doing a transrectal scan in those patients is quite helpful because if you do a transrectal scan, you'd be able to visualize the vaginal compartment in front of you in comparison to doing a transvaginal scan where you won't actually see the vagina easily. So doing transrectals, particularly in patients with suspected lower genital tract anomalies, is actually quite helpful. So this is actually the ultrasound images of this patient. She had, if you see here, this is the picture of the unicornuate uterus. So this was the horn on that side with the obstruction. She had hematocolpus only. She did not have hematometra. And by the MRI imaging, she had a normal right side. That's the uterus, and that's the normal draining vagina. And she had a left vagina with distended blood. Luckily, she did not have hematometra as well because of the fistula she had between both ends. And what we did is actually hysteroscopic surgery. This was actually a virgin, so we went in with a scope. And what we aim to do is to, first of all, find landmarks to start our surgical procedure from. So this was the distended vagina on that side. And we started by finding where the cervix is and start the dissection or opening the 2 cavities together by knife hysteroscopy, starting from the cervix downwards. So we have a starting point to do it. And actually, we did that while the patient was menstruating. So we're opening the lateral vaginal wall now to actually open the 2 cavities of the vagina together to be able to drain the menstruation that's coming from the left side of the blocked uterus into the normal draining vagina. At some point now, I'm going to be going inside that end. With this one, we were using saline operative hysteroscopy using bipolar diathermy. Okay.